Hi, my name is Dr. Ujjwal Shake, and we have Dr. Danny. And today we'll talk about and discuss a few of the evaluation technique we do at MSR. We're going to divide those evaluation assessment tool that we have from upper body and lower body, regardless of whatever diagnosis it is. So we're going to start with maybe upper body today for right now for this video. Okay. So regardless of whatever the diagnosis is, so for upper body, for me would be anything wrist, elbow, shoulder, neck, even thoracic and upper back for me, a chest, in those areas in the realm. Lower body will be from lumbar and down. So that's how I'll categorize it. Obviously, sometimes it can be both, but the first simplicity I'll do that way. Okay. So I did the subjective part. I asked all the questions, rule out the red flags, and the first thing I would do is, doesn't matter what the diagnosis is, just for sake of example, we'll take it as a shoulder case. Okay, so I'll have patient sit down, and if the patient is for shoulder, I still want to see how they move, and I'll ask them, all right, go ahead and stand for me, and I want you to go ahead and walk for like 5 steps. I'm looking for big things here, so come back and walk back again, So because this is a shoulder case, I'm not gonna spend too much time on their gait analyses and their knees or hips so much, unless it's really telling me something is obviously wrong. Okay, so I'm looking for more for symmetry more than anything else, and obvious symptoms and signs. Okay, so since it's shoulder, I'm gonna assess more of upper body, but I'm not gonna dive into shoulder the first thing, because I don't want to aggravate the shoulder, because everything else will be false negative or false positive after that. So I want you to assess everything else, and at last shoulder, if shoulder is a subject that I'm working on. Okay. All right. First thing we'll do, Dr. Danny, I want you to put your head down all the way, look up all the way. So I'm trying to work on the neck range of motion. Come back, turn to your right side, left side, come back, stab into right side and left side. Again, I'm not gonna ask my patients like, does it hurt? Does it hurt all the time? Because if I ask all those things, I'm just gonna waste my time, because she's gonna answer me every time she's gonna talk, and it's just gonna take too long. So the first thing I'll say is, if it hurts, just let me know, rather than me asking, does it hurt every time? Okay. Again, I'm looking for big things. I'm looking for symmetry, and I'm looking for symptom reproduction. Okay. Next thing will be, since I'm not gonna assess the shoulder immediately, I'm gonna go back to maybe elbow. Put your elbow all the way up, all the way down, all range of motion, pronation, supination. We'll go to wrist all the way up, all the way down, ulnar deviation, radial deviation. Again, I'm looking for symmetry and also looking for symptoms. Again, now I'm saying, now we're gonna go back to shoulder. Okay, we're gonna go back to shoulder now. Go all the way up, down, sideways. Go all the way up, down. Functional range of motions. Go behind, go behind. Again, I'm looking for symmetry, I'm looking for symptoms, and then we can go from there. By this time, I will have some idea something is going on with the range of motion. There is some symptom reproduction going on. Okay, since he's already standing, I can do few things in standing position. So I don't want to keep going back from sitting, standing, lying down. So I would like to do everything that I can do in standing. Okay, and if I feel like somebody is a little older, somebody has a little bit more comorbidities, I can say, oh, go ahead and stand on one leg for me. Is that's applicable for you? Do the other side. Very good. Somebody has a history of neck pain and back pain, might as well go ahead and bend down, touch your toes for me. Come back up, arch your back. Come back out into right side and left side. Side into right side and left side. Again, we don't have to do all these things. The idea is to kind of see how that information is important based on whatever the medical history you have, or this history of the patients came out to be as you do an interview. You don't have to do all those things. Now, since we do the range of motion testing, we have some ideas. Since he's already standing, and then I can just do a couple of things with palpation. So I know this is kind of painful area. I'll go to the other area that is not painful, just to kind of see, all right, does it hurt? Okay, so I'm poking around the areas. Okay, now I'll go back to the affected area and see if that's painful. So I'll have some ideas with the palpation, which one is tender. Again, it should not take too much time. If there is one area which is painful, all right, you're going to point out that, all right, that's painful area. We'll keep that in mind for the later. Okay. Now I'm going to go to MMT. Again, this is shoulder. That's affected. So I'll go back to the other area. The first thing I'll do with the left shoulder, hold it there. Then you push it down. Telling me push it down, telling me push it down. Okay, we're gonna do the same thing, empty can, turn all the way. Very good. Again, I'm looking for symptom reproduction. I'm looking for quality of contractions. Yes, I'm doing MMT. I'm trying to grade 2. My goal here is symmetry, symptom reproduction, and the quality of contractions. In the meantime, I'm trying to grade 2. Okay. Go inside. Internal rotation, extension. Very good. So since I'm already here, I'm going to do a couple of tests. A little bit of near test. Looking for impingement, a little bit of a Hawkins Kennedy. I'll have her go all the way up, O'Brien a little bit, go all the way up. Very good. Gentle little bit of 90-90 if I feel it's applicable. There are a few other tests, like I do it as needed. Okay, relax. Okay, same thing, go all the way up. Hold there, hold there. Outside, inside. Again, by this time I will have some idea where I'm going with, once you find something, then I can dig deeper. Like, for example, let's take in, for example, I go ahead and push in. If internal rotation is painful, then I can do internal rotation in a lot of different ways to make sure, is it usually coming from the muscles, or is it coming from joint compression, is it coming from something else? So if this is painful, go ahead. Then I could do the same test in little open pack position, go ahead. If this is not painful, then most likely the muscle is not the primary tissue that is being affected. Because if this primary tissue was affected, this should be the same or more than this. Because in both range, muscle is being contracted. But in this range, the joint is not as compressed, the joint is more compressed in this region. So that's how we can rule in and rule out a few of the tissue to figure out what tissue is more affected and what tissue is not as affected. Okay, if I find out, okay, this is more painful and this is not painful, then you can do a passive range to see if I compress the shoulder, is it more painful or not. If this is more painful and this is more painful, this is less painful, then it means the open pack position is this painful. That means the joint is being more compressed, which is causing the contraction of subscap, or biceps or pec will cause more pain. So again, muscle is secondary will be here, joint compression will be a primary here. So that's how we can rule in and rule out. Makes sense, right? Okay, very good. Okay, so that's later on though. I'm going like a little bit ahead of time right here. So if I do all the things in standing, I'll have this doing some sitting. Go ahead, have a sit for me. So I have a rule here. I want to make sure if it is a lower body, I would like to rule out any kind of radicular symptoms. So for lower body, a slump, SLR, PS stress is a must, just to kind of rule out. Same thing with upper body. I like to check spurling, just to make sure the spinal nerve is not being affected, any kind of herniation, stenosis is out of the order. Okay, so I'm gonna have her neck rotation to the left, extension and side bending, go right here, do the same thing right here. So by just doing that simple test, you can basically say, all right, spinal nerve is not being as affected, herniation is not so much of an issue, so we can think of whatever the affected area is, which is probably the shoulder is. Cool? Okay, so that's the first thing I would do from the sitting position. Okay, I can also do sitting or standing. We can do a little dermatomes just to make sure sensation is intact and bilateral and symmetrical. Okay, and then since sitting is good, now we'll go back to the supine position now. Okay, lean it back for me. Now in supine positions, I can spend a little more time on the affected area, just to kind of compare with the affected area. I'll go back to unaffected just to kind of check the joint play, especially with the shoulder. If I'm looking at this, I'm looking for passive range of motion. While looking at the passive range of motion, I'm also looking at how the in ranges are, if it is painful, if it is a springy, if it is a hard infield. Okay, very good. I'll do the same thing on the right side now. Okay, relax. Okay, passive range of motion. Relax. And this is very important because if I suspect if this is a labrum tear, there's instability going on, then I do not want to put in a really, really uncomfortable position, because I can potentially cause any kind of dislocation or subluxation of the patient. So I'll just go to the range to where pain is being affected or apprehension, but I will not go beyond that, or I will not go too fast, Okay, very good. Now go ahead and lay in your stomach. So this will be a last phase of the evaluation where, in prone positions. The first thing is palpations. Always ask permissions, and then I'll kind of like push on the spine a little bit more, posterior anterior stress test. I can go from cervical to upper thoracic to lower thoracic. I might as well even lumbar too, just to kind of see if there's any kind of radicular symptoms, how the mobility is, looking at the paraspinals, a little bit of scapula, and then we can do a quick scapular retraction testing over there. Thumbs down, thumbs up, a little bit more behind. Very good. We can do bilateral too, very good. Stand for me, sit for me. Good. Any questions? Tom, any questions on where to go where?
I think like what is your thoughts on like special testing?
Well, great questions. Special test doesn't have a lot of research on to distinguish which one is causing what. So there's not strong research on sensitivity and specificity. However, there are a lot of research out there. If you combine the special tests, you have a better idea what it could be. So always don't rely on one special test. So for example, if you get empty can positive, don't say it's supraspinatus. It could be, but it could be a lot of different things too. So if you feel like in the if the empty can is positive, then also look at what's the how the symptom gets affected when you compress the joint. How the symptom affect if you change the position but contract the same muscles, right? So if I'm doing a supraspinatus, what a supraspinatus does? So any kind of overhead activities, right? Flexion, abduction, scaption is a major supraspinatus activation, right? Does it change when you do those things? Is it more on abduction or less in the flexion? Because it gives us some idea. Does it change when you are in the beginning range or the end range? So any kind of those, because if muscle is being affected, a contraction of muscle will have more symptoms. Passive range of motion will have minimum symptoms. Stretching of the muscle will have some symptoms. Palpation of the muscle will have some symptoms. If you have more symptoms with the passive range of motion, least likely the muscle is being most affected. Am I making sense to you? So again, going back to yes, do the special test. The study has been done, so you can have some idea, but don't rely on just one special test to give you what is for. Use the tissue specific stuff. If you think it's a muscle that's being affected, test the muscle in different ranges. Stretch the muscles, palpate the muscles, compress the joint, and now test the different surrounding muscles and surrounding tissue. So how can you affect the tissues? You can stretch the tissue, you can compress the tissues, or you can contract the tissues. I'm talking about all the tissues around the area, right? So by doing all those things, you're gonna have some information. And based on those informations and based on the mechanism of injury, and based on the severity of symptoms, and based on what the stages of the injury is, you can have an idea which one is a primary, which one is secondary, and which one is tertiary, or then further or more. There's no such thing called this is this. It is based on your assessment. It is based on your judgment. It's based on all the data that you can get. And if you can defend that, you be the judge. Make sense? Okay. So if you come up with something and you say it's because of this, you defend that. For example, I'll give you supraspinatus, right? For supraspinatus to be the primary tissue lesion, I would imagine, endocan would be the most painful. I would imagine abduction would be most painful. I would imagine if I passively move an arm, even if it is painful, it won't be very painful. If I compress the joint with the impingement test, it should not be the most painful test, right? And if it's a pure tendinitis, me doing more activations should actually help. That's the classic hallmark of tendinitis, right? And I should not be complaining about a lot of instability or clickingness. Now, these are my thought process of what a supraspinatus would look like. It doesn't mean it's always going to look like that, but that's what I believe it should look like if the muscle or tendon is being involved.
What are your thoughts on clicking?
So clicking is a great question, like, you know, so if somebody has clicking, like, you know, it doesn't mean it's a bad thing, you know, and evidence has proved that. Now, if somebody has clicking with limited functions, like they feel unstable, they feel weak, you know, they have sharp pain, you know, they cannot do the job, or they cannot do the function, then that they have a clinical click. If you have a clicking, but you can do everything that you can, you may have minor pain, it's more for psychological than more physical, then you have a functional click. That's my definition. I rather want to have the functional click rather than a clinical or pathological click. You know, a click with sharp pain, click with dysfunction is not good. It's just a sound with a more psychological, something bad's happening. Usually that doesn't mean much. It usually means there's some kind of friction is happening between the tissues. It could be a gas being produced between the tissues because of the rubbiness or the friction. You know, it could be tendons kind of colliding with the bones. You know, it could be just a cartilage grinding. You know, not a bad thing as long as it's not pathological. Fair? Cool. Any questions? Okay, so the whole idea of the evaluation is, especially for me, again, everybody's biased, like, you know, I'm trying to have a system when I do evaluation, and I want to try to be efficient, and I want to try to be fast. You know, this is why I teach my students, like, you know, you want to have everything in standing, sitting, lying down, and prone, and I want to make sure you do everything in order, because if you do everything in order, one, you're going to be really good at it, you know. Second, you're going to be so efficient that, you know, you're not going to miss much, you know. And third, if you know what the positive is, rest everything's a negative. That means your documentation is going to be a piece of cake. Because if your documentation is this long and all you just click is 3 positive, rest everything is negative, that means you have done 100 things, but you only focus on 3 things, you know. Then you are like just playing chess. You are 10 times, 8 times ahead of the game. So you can focus your time on what are you going to do with the patient that day, you know, how you're going to be doing good things or good treatments or effective treatments so you can improve the patient's anxiety level. Every patient who comes in evaluation has some form of anxiety, some form of stress, you know. Our job as a clinician is, how can we reduce the stress? How can we improve the confidence? How can we have them saying in the back of their mind, he or she is the person that can help me with what's going on with me. You know, before I leave my evaluation, I'm gonna have the confidence, you know what, I came to the right place. You know, I think he's gonna help me, you know. And as a clinician, what I would advise everyone would be is, don't focus on the end goal. Don't focus on, I'm gonna fix this patient. I'm gonna understand what the diagnosis is today, rather than trust the process, do your evaluations, you know, come up with whatever you come up with your evaluations, rather than focusing so much that you miss out on what you're supposed to do, and you look confused, you look phased, you know, and you come across like, you know, there's a lot going on and the confidence is not coming up. Sometimes less is more. You know, you don't have to heal the patient on the first day, but make sure you build the confidence between the patient and the clinician interaction. You know, he should or she should, when she leaves, like, you know, I feel good about this. And that will come across on how you caution, how you examine the patient, how you teach the patient, you know, tell them what to do, what not to do. These are some intricate things. When you do them, the patient is always judging you, just like everyone is judging each other, right? And you have that first impression that you're gonna make, you know. And if you just focus on, I need to know the diagnosis, then you're putting too much pressure on yourself, resulting in it's gonna affect how you perform. Because sometimes you're gonna be like doing all the things, I don't know what's going on. It will happen a lot. Trust the process. You're doing an evaluation, you're coming with something, you know, tell the patient it's good news. Instead of saying, you know what, I don't know what's going on, I'm very confused, tell the patient, you know what, I did everything and these are all the good news that you have. Since you tell me you have shoulder pain, I want you to avoid these things and I want you to work on this, I think it's gonna be good. Instead of looking face, I have no idea what's going on because I couldn't come up with a possible answer. you know. So don't trust don't focus on the result, trust the process, because you're only going to put more pressure on yourself, and it will come across in a lot of different ways, and the patient is sensing everything. It's a subtle things, but an important thing. Any question on that? Good.